So this is the cotton clunk test, and this test is used to test for a potential high ankle sprain or syndesmosis, and the patient will be lying supine. So then the examiner would stabilize the distal tib-fib joint with one hand and use the other hand to grab at the calcaneus and apply a lateral translation. A positive test would if you hear a clunk or if you have 3 to 5 millimeters of movement, and a positive test would indicate syndesmotic instability. So again, you're going to stabilize the distal tib-fib, and then you're going to take your other hand to make sure your hand is getting near the talus, and you're trying to move the talus laterally. So you're going to give that lateral glide with your distal hand. So again, you're looking for reproduction of the patient's complaints, or if it's really lax, and you may get a clunk, something basically moving the talus within the mortise. So this is the medial subtalar glide test, and it is similar to the cotton test. So you will have the patient in the same position in supine, but this time you will be applying a medial glide or translation force. So you will also be stabilizing the distal tib-fib joint with one hand and then grabbing the calcaneus with the other hand. But again, for this test, you'll be applying a medial translation on the calcaneus. So a positive test would be reproduction of the patient's pain, which would indicate some instability of the mortise or syndesmosis or high ankle sprain. So again, you're going to stabilize with one hand and your distal hand is pushing medially. So what you're trying to do is move the talus within the mortise, kind of a gap over to see if it reproduces the patient's complaints. So this is the Kliger external rotation test. This test is used to isolate out a high ankle sprain from a lateral ankle sprain, and the patient would be sitting at a short sit position at the edge of the table, and you would make sure that the patient's knee is in a 90-degree angle and let the leg stay in a neutral position. So then you would stabilize the distal tib-fib joint and grab with your other hand the bottom of the calcaneus, and now you're going to apply an external rotation of the foot. And a positive test is if there is pain at the distal tib-fib ligament or syndesmosis, or if it reproduces the patient's pain. So you test the uninvolved to the involved side. And again, what you're trying to do is grab the calcaneus while you stabilize the tibia, and you're going to externally rotate the foot. So you're trying to twist the talus around. So if there's been a high ankle sprain, you're gapping open that mortise and you would reproduce the complaints of pain. So this is the fibular translation test. This is another test you could use to assess for the possibility of a high ankle sprain. The patient will be side lying with a tested leg on top. So you would stabilize the tibia with one hand and then grab the fibula with your other hand by grabbing proximal to the lateral malleolus. So you're going to use either the heel of your hand or your fingers to do an anterior and posterior translation of the fibula. And you would make sure that you get your forearm in line with your heel of your hand so you have a good line of force. And a positive test would reproduce the patient's pain. So again, the patient's going to lie on their side. You find proximal to the lateral malleolus and find the fibula and use the heel of your hand to apply a posterior translation. And then you can also wrap your fingers around the fibula, especially if someone is not that large. You can try to do more of an anterior translation with your fingers. And if the person was a little bit bigger, you can always come around to the other side and push from this direction. This is the squeeze test, and if you're trying to decide if it is a lateral ankle sprain or a high ankle sprain, you can do this test, which is more specific for a high ankle sprain. So what you want to do is you're going to put your hand well above the malleolus because you want to stay away from the area where there might be swelling or pain. And then you're going to come up onto the distal third of the tibia and fibula, and then here you're going to compress across that area. If I reproduce the patient's complaints of ankle pain, then that's probably because there's some sort of syndesmotic interruption, and that compression that's happening up higher is translating to something painful. So that will be considered a positive test. So I'm just lifting the other person's leg just so you can see me do it on the other side as well. This is the heel thump test, and this is performed to force the talus into the mortise in an attempt to impose a separation of the distal syndesmosis. So the patient is lying prone with their feet at the edge of the table with their ankles resting and in plantar flexion. So that you are going to hold the patient's leg with one hand at the distal tib-fib joint, and in the other hand you would make a fist and then apply a gentle but firm thump on the heel of the foot. And this force is applied at the center of the heel and in line with the long axis of the tibia. And if there is pain experienced at the distal tib-fib syndesmosis, it suggests that there is a presence of injury. So again, you're striking the calcaneus and you're looking to see if it reproduces the pain in the syndesmosis region. Remember, this test also checks tibial stress fracture, but with this, you're looking for pain in the tib-fib ligament and syndesmosis area, not the shaft of the tibia. This is the anterior drawer test, and this test can be used to assess a patient post-ankle sprain to examine lateral collateral ligament instability. This also will test the stability at the ankle for people who've had chronic and recurring ankle sprain. So you would have the patient lying supine with their feet extended off the table and make sure their foot is in 20 degrees of plantar flexion and the patient is relaxed. You would then stabilize the distal tib-fib joint with the other hand, and you would cup under the calcaneus and you would pull the calcaneus towards you. So pull it up or pull it up anteriorly. And a positive test would be the feeling of excessive translation when comparing sides, or you would hear a clunk. If that test is positive, that tends to implicate more the anterior talofibular ligament. This is the Taylor tilt test, and this test is used to assess for lateral ankle sprain. You can do this supine or side lying, and in supine, you have gravity working with you. So you have the patient relaxed, and you're going to get right over the talus, coming to the calcaneus, and just superior to that, just of the inferior edge of the lateral malleolus. And you're going to do is try to create an inversion with the talus and see if you can get excessive gapping. And if that were to reproduce the patient's complaints of lateral ankle pain, or if there is excessive motion or a clunk compared to the other side, that can be more indicative of a possible involvement of the calcaneal fibular ligament and as well as the anterior talofibular ligament. This is the Holman sign, and if you have any concern about vascular condition with the patient that you are seeing for the calf, foot, and ankle, and you suspect possibly a DVT, you can do this test. So what you're going to do is come and squeeze the calf, and you're looking for the reproduction of their calf tenderness. And oftentimes, if someone even just has a partial calf tear, it's going to be tender. So again, this test is not specific, but what you can do is try to sensitize the test a little bit by moving the foot into some dorsiflexion, as well as squeezing and seeing if you're reproducing some of that deep calf pain. So you would want to correlate this test with also looking at other tests for vascularity. So looking for maybe a dorsal pedal pulse, maybe posterior popliteal pulse, or color changes. This is the Berger's test, and this is another test you can do to test for possible vascular insufficiency if someone may have peripheral vascular disease. In this case, what you're going to do is elevate the leg, and you want to hold that for about 3 minutes. And then while you're doing that, you're looking at the foot to see if there's any blanching or any collapsing of the veins. And then after 3 minutes, if you see that, then you can feel good about calling it a positive test. And then if you put the leg down and let it dangle off the edge, if they fail to have full return of color quickly within 30 seconds, then that is considered a positive test. This is the Thompson's test. So this test is assessed for an Achilles rupture. So you would begin by having the patient in prone with their feet hanging off the edge of the table. And what you are going to do is squeeze the calf muscle belly, and you're looking for a passive plantar flexion at the foot. And if there is absence of the plantar flexion, that would indicate a complete rupture of the Achilles tendon. And one thing to remember about this test is the sensitivity value is very low, and a positive Thompson test is valuable, but a negative test does not mean the Achilles tendon is undamaged. So you can see that the Achilles is intact because you are getting that result of plantar flexion at the foot. This is the Matlis test, and this test is also assessing for Achilles tendon rupture. So you have the patient lying prone and ask them to bend their knee up to 90 degrees, and you're watching what is happening at the angle at the foot and ankle. And if the Achilles is compromised as the patient bends up and gravity is pulling the foot down, you would start to see possibly a slight foot drop or lag, and that would be considered positive. If there's no drop or lag, then that would be negative. This is the Royal London Hospital test, and this is a clinical test for Achilles tendinopathy. With this test, the patient is lying prone, and you try to find the area with the tendinopathy, and you squeeze this area. This should be uncomfortable, so don't squeeze or pinch too hard, and start slowly and see if you can reproduce the symptoms. All you do is squeeze when you find the threshold of pain, and release your fingers just a little bit, and then have them maximally dorsiflex. Then again, squeeze the area with the same pressure you had before. If that area was tender to palpation originally, is less tender during active dorsiflexion, then this would be indicative of a tendinopathy. This is the Tinel sign, so you are tapping over one of two nerves. So you would typically do this test at the anterior branch of the deep fibular nerve, which is on the anterior portion of the ankle. So you would put the patient in slight plantar flexion and tap over that area, and seeing if this reproduces the patient's pain or numbness or tingling that occurs, which would be a positive test. Or more commonly is posterior to the medial malleolus is the tarsal tunnel, which is trying to elicit a response of the posterior tibial nerve. And a positive test is, again, if you reproduce the patient's nerve complaints of numbness and tingling. This is the Morton's test. It's another neurological test, and this is for a patient who's coming in complaining of metatarsal pain, and you're worried that they may have Morton's neuroma. So what you're going to do is you're going to have the patient positioned in supine, and you would grasp the foot around the metatarsal head and squeeze the heads together for the reproduction of pain, meaning numbness or tingling, which would indicate something neurological is going on. So the maneuver could indicate the presence of neuroma or stress fracture. This is the phase line test, and it is used to assess the height of the medial arch using the navicular position. So first you would assess the patient in non-weight bearing, and you would mark the apex of the medial malleoli and the plantar aspect of the first MTP joint, and then you will draw a line between the 2 points, or an imaginary line. The navicular is then palpated on the medial aspect of the foot, and you would make the assessment of the position of the navicular in non-weight bearing, then take note of that. Then you would ask the patient to stand up approximately with their feet 3 to 6 inches apart, and then you would again assess the navicular position by palpating and assess its placement between the first MTP and the apex of the medial malleoli. And the line should actually be where the MTP joint comes in contact with the ground. And then if it clear falls in between or just below the line of the first MTP and the apex of the medial malleolus, that is normal. And if it is higher than that, it might indicate the patient has a high arch. And if it is lower, then this could indicate a low arch. This is the functional hallux limitus test, and this is a test you can do to test the first ray and hallux MTP mobility. The patient will be lying in supine, and the first thing you would do is put the patient in subtalar joint neutral. So you would first maintain this subtalar joint neutral with one hand, and then the other hand will passively perform big toe extension. And if the first ray plantar flexes into great toe extension, that would indicate a positive test. This is the windlass test, and you can do this if you're worried about plantar fasciitis issues or if you're trying to reproduce the plantar heel pain. And the patient would stand on a box or a step with the metatarsal heads just over the edge of the step. And we are just doing this on the table just for the purpose of this video since we did not have a step nearby. So the patient is instructed to place equal weight onto both feet, and then you would passively extend the MTP joint, and then you again are creating that tension via the windlass effect. So it is positive if the passive extension is continued to end range or until the patient's pain is reproduced.